My name is Rebecca Barron. I'm a member of the Pulmonary and Critical Care Division at Brigham and Women's Hospital and a medical ICU specialist taking care largely of septic shock and acute lung injury patients. And I'm pleased to talk to you now about septic shock principles and practices of resuscitation. A companion talk to this by Dr. Ree will address the new definitions of sepsis and talk in more depth about other aspects of sepsis, and we'll focus largely in this talk on resuscitation. I have no disclosures. And again, just to reiterate, for more in-depth discussion about the new definitions of sepsis, which just were published last year, in JAMA, as you can see here, please see Dr. Ree's talk, but just to set the stage for what we'll talk about in this session about resuscitation, there was a recent consensus definition that was published termed Sepsis 3, and listed here is the updated consensus definitions of sepsis that, since they were just published, there's still a lot of ongoing discussion and evaluation of how they compare with the old definitions, but for the purposes of our discussion, we'll be referring to sepsis based on these principles. Sepsis, as defined by this consensus conference, was felt to represent at least a 10% mortality, defined by life-threatening organ dysfunction caused by a dysregulated response to infection, and this was a change from the prior definition in the sense looking really for end organ dysfunction as indicated by an increase in the SOFA score of at least 2. Greater than or equal to 2, which represents multiple organ systems. And then septic shock is defined by the consensus conference represented at least a 40% mortality or greater than 40% mortality, and defined by refractory hypotension, essentially requiring vasopressors to maintain a mean arterial pressure, indicated by an elevated lactate greater than 2 by these definitions, despite adequate fluid resuscitation. And again, for more detailed discussion about these new definitions, their derivation, and other aspects, please see Dr. Ree's talk. I'll mention just briefly another production of this consensus conference was this Q-SOFA, or the quick SOFA score, defined as indicating a concern for sepsis, meant to be used in out-of-hospital, emergency department, or ward settings, not in critically ill patients. And by this metric, worse outcomes were predicted from sepsis with 2 of the following: a respiratory rate that was elevated, altered mental status as indicated by a Glasgow Coma score, less than or equal to 13, and hypotension is defined here. And like the new definitions of sepsis, there's still a lot of ongoing debate and discussion about how best to utilize the Q-SOFA, how it should be implemented, and requires additional real-world validation, I think, prior to widespread agreement upon how it should best be used. But just to put that point out there. As I have mentioned, I will now turn our attention to principles of management of shock and fluid resuscitation, and we'll leave some of the other aspects of sepsis to the other discussant. And there really is no way to talk about fluid resuscitation without going back to recent history to talk about early goal-directed therapy, which was a seminal paper published by Manny Rivers and colleagues in the New England Journal in 2001. And for the last 14 years or so, this has been the hallmark of our resuscitative strategy largely. And I want to go through the data. I want to go through how it changed our practice, and then I will give you more recent data that is causing us to reevaluate how we apply the findings of this study to fluid resuscitation. So in this study, early goal-directed therapy, early meant, which was a landmark development for this trial, the treatment really began in the emergency department. And there was a 6-hour period of resuscitation in the emergency department. And that was really new for these types of studies, that early really meant from the time the patient hit the door. The patients had A lines and central lines placed. They were monitored in terms of their mean arterial pressure, the central venous pressure, which I'll talk about more on a subsequent slide, their central venous oxygen saturation, which I also talk about, which was derived off a central venous pressure monitoring system, and their hematocrit. And again, I want to go through the details of the study because I think it really altered the way many of us think about resuscitative strategies in sepsis, and largely informs how we're thinking about resuscitative strategies moving forward. What was very interesting about this trial is it used continuous central venous oxygen content monitoring, and subsequent to this trial, many people did use central venous saturation assessment, but not with continuous monitoring, just by drawing blood gases off of the central line. And what was interesting, this and other data suggested that a central saturation of at least 70 should, in theory, indicate reasonable balance of supply and demand. And shock, obviously, is the state when oxygen supply does not match demand. And the goal of resuscitation in any type of shock, and in septic shock, which we're talking about here, is getting adequate oxygenation to the tissues. So if oxygen delivery is not adequate to meet the tissue demand, then the central venous sat may be less than 70, and that's what was monitored in these trials. And I want to take you through this intervention that was early goal-directed therapy. Again, that was how many people managed sepsis, at least the top part of this algorithm. And the top part of this algorithm was what many people, I think, still adhere to and are thinking about very carefully. So patients were stabilized. They had a central line placed. They had their central venous pressure monitored. They were resuscitated with crystalloid. And what was interesting in 2001, it doesn't seem so now, but 500 cc's of fluid every 30 minutes for a medical patient was a lot of fluid. At the time, I think many people were cautious and concerned that patients who might have comorbidities like cardiovascular disease and renal dysfunction couldn't tolerate such an aggressive rate of fluid. And I think many people believe that this intervention is what really was a major change in how we as a community manage resuscitative strategies in sepsis. And we'll talk a little bit about crystalloid versus colloid, but largely the practice has rested upon crystalloid. Then if the central venous pressure was rescued, and or if the patients remained hypotensive, they were given norepinephrine as the pressor of choice, and we'll talk about that, the data behind that decision. So the upper part of this algorithm is still really the basis for how we think about fluid resuscitation. Importantly, there needs to be adequate filling of the tank. This equation here represents why that's important. This is the mean arterial pressure minus the right atrial pressure is equal to the cardiac output times systemic vascular resistance. So if you squeeze up the SVR, the systemic vascular resistance, with the vasopressor, you may increase your blood pressure, but it might be at the expense of cardiac output. And cardiac output really depends upon adequate filling of the tank. And obviously, as we'll talk about on a future slide, oxygen delivery, cardiac output is a critical component of oxygen delivery. The bottom part of this schematic is what is largely, for many people, been called into question in terms of using this as an ongoing strategy. But I want to go through it again just because this entire algorithm was evaluated in this study. And so the investigators then used the central venous saturation. As we discussed on the prior slide, if that was less than 70%, the other component of oxygen delivery includes the hemoglobin. So they, which we'll talk about on a subsequent slide. So they infused red cells up to a hematocrit of 30, which is obviously controversial in the setting of data that has continued to emerge, suggesting that critically ill patients without ischemia or other comorbidities likely don't require such a high hematocrit. And then if the central venous saturation remained less than 70, then they used an inotropic agent to improve cardiac output. If the goals were achieved, and they used dobutamine as that agent, if the goals were achieved, they were admitted, and continued management was pursued in an ICU or in the appropriate location. And if not, then they continued on this pathway until the goals were achieved. And this slide just shows that they managed to achieve the goals set out for the early goal-directed therapy group. So at baseline compared with 6 hours, the early goal-directed therapy group had achieved the goals relative to the standard therapy group as listed here in terms of central venous saturation, lactate, base deficit arterial pH. And then what has been the topic of intense discussion over the last 16 years since this trial came out is what was the basis for the improvement in this trial? What was the benefit? that could be inferred, or what was driving that benefit. And what was interesting is that in terms of the total fluids, by 72 hours, both groups had gotten about 13 liters of fluid. What was interesting is that by 6 hours, the early goal-directed therapy group had gotten significantly more fluid. And so the larger component of this fluid resuscitation was delivered earlier in the early goal-directed therapy group. And I think many believe that this is the critical finding and the critical change in practice that has really driven how we think about sepsis and sepsis resuscitation, and perhaps may underlie improvements in sepsis that have been observed internationally. Not surprisingly, there were more red cells given because of the protocol in the early goal-directed therapy group. Use of vasopressors was not different, which is probably to be expected because I think that's an appropriate reflex when someone is hypotensive. And as we talked about on the prior slide, one wants to be certain that there's adequate fluid resuscitation. And then probably also not surprisingly, there was more use of an inotrope in the early goal-directed therapy group because of the protocol. And what was striking about this study is that for the first time in many years, and it was a unique outcome at that time, is that there was a striking mortality benefit in the early goal-directed therapy group. It was a 30% mortality versus 46% mortality in the standard therapy group, which was a significant result. There have been many critiques of this study, one of which was that the standard therapy group was obviously a quite sick population. This was an inner-city hospital, Henry Ford Hospital in Detroit. Overall, as we'll talk about, our standard of care has likely improved over time, and so this and other caveats have certainly been raised as this trial has been analyzed and reanalyzed over many years. But one key question that has persisted since that time is this benefit in fact reproducible? And what is driving the benefit? Is it really an entire algorithm, or is there a particular approach that we can rest upon that is the driver of this benefit? So this is just indicative of some of the pro-con debates that have gone on over the years. And for those who are interested, this is an interesting debate between Emmanuel Rivers, who was the lead author on early goal-directed therapy, and another well-respected intensivist, Gregory Schmidt, in CHEST a number of years ago. As you might imagine, Dr. Rivers was arguing that we've shown the benefit of early goal-directed therapy, and Dr. Schmidt was suggesting that we need to investigate further what the exact aspects of resuscitation are that were beneficial. And so an interesting approach. And this debate in many circles has continued in terms of how we best manage sepsis. And so in the last 3 or so years, 3 large internationally carried out trials in terms of the 3 different trials were across 3 different continents, have looked at early goal-directed therapy and reevaluated protocolized based care for early septic shock. So I'm showing you just one example of these trials. The one in 2014 in the New England Journal shown here was carried out in the United States by the process investigators. And what they found in examining 1,300 patients or so was that comparing early goal-directed therapy based on the protocol I just showed you versus what I will call early goal-directed therapy light, the sort of protocolized care without the bells and whistles, without the central line, the inotropes, the blood, or the lower part of that protocol, meaning the fluids and the pressors, versus usual care. And what was striking about this trial, in contrast to early goal-directed therapy 2001, was that there was no difference in the primary outcome of 60-day in-hospital mortality or any other outcomes. And this was a surprise, and I think quite stunning. And what I think is more convincing is that there were similar results from 2 other large trials. One carried out in the UK, and the other carried out in Australia and New Zealand, and in the ARISE and PROMISE trials that are listed here in the New England Journal. So as best as we can tell, early goal-directed therapy as applied in 2001 did not show the same mortality benefit in 2014 or 2015. So what does this mean? And there's still a lot of discussion and debate and talk about other trials that will be needed to help guide our resuscitative strategies in sepsis moving forward. So a few things. One, mortality in the usual care group has substantially declined in these trials. So it was 46%, as I showed you in the early goal-directed therapy trial in 2001. In 2014, it was 18%. So usual care has certainly evolved. And I'll show you some data that we've generated that supports that premise. The patient populations were a little bit different. As I told you, 2 other large trials had similar results. And I think the trend was already moving in this direction, but I think these trials support that general practice should include early antibiotics, meaning as soon as is possible in a patient with concern of infection or sepsis. Every hour that antibiotics are delayed causes an increase in mortality. And early fluids in a judicious manner. And we'll talk more about that. What does that mean? And I think that's what we are, as a community, are working on trying to figure out. We know that early fluids are important, early antibiotics, early resuscitation is important, but is too much fluid dangerous? And we know from studies of lung injury that interstitial edema and side effects of fluid are not beneficial. So there's, like all things in critical care, there's likely a Goldilocks scenario where there's an adequate and correct amount of fluid that needs to be delivered at the correct time for optimal resuscitation. And these studies support our lingering uncertainty regarding whether every patient needs a central venous catheter. Certainly, the practice has really moved away from use of upfront red cells for a variety of reasons that we discussed in another trial in 2014 in the New England Journal, also supported a restrictive transfusion strategy. And upfront use of dobutamine. Obviously, in patients who have cardiogenic shock or mixed picture shock, there might be roles for inotropes, but not in the protocolized manner that was put forth initially. And I'm going to show you the changes as a result of these trials to the surviving sepsis bundle that were just recently published. So I just want to show you a little bit of data from our ICU collected by some of my colleagues. And what this shows in our review of time to antibiotic administration, either from ED arrival or from hypotension onset, has really decreased over time. So if you look we reviewed a large database from our hospital, and you can see that over time, the time to antibiotics has really improved. So our management strategies have evolved and improved over time. And similarly, we're quicker at getting fluids into people, which I think we're happy to see that that's been a positive result of the data that's been produced thus far. So how do we figure out what the correct fluid balance in sepsis is? It's a really difficult question. We don't have optimal data to tell us exactly what the fluid balance should be. We know that we need early resuscitation. We know that we need adequate resuscitation for adequate oxygen delivery and tissue perfusion. But exactly how to gauge that or how to determine where that is or when to institute pressors relative to fluids is still an evolving question. There are conflicting results, but a few small studies suggest that a positive fluid balance may not be beneficial, especially later in sepsis, and there is data to support that a positive fluid balance is likely not beneficial in acute lung injury and ARDS. So there will be more data coming out, and the National Pedal Network may address this in a future study as well, which is the Prevention and Treatment of Acutely Injured Lungs Network sponsored by the NIH. So I just want to talk with you about the pathophysiology underlying sepsis, just so we can talk about some additional therapies and supportive measures and the basis for them biologically. So we believe that sepsis is driven by infection, and an infectious organism may release a toxin and trigger signaling of various different molecular pathways. There's then the response of the host to that infection, which is usually a robust pro-inflammatory response, though obviously that can be tempered given the immune system of the host. And we know emerging data has suggested that there's a immunoparalysis, a later anti-inflammatory host response. So where the balance of this for each patient at each point in time is not entirely clear. Many therapies over the decades have targeted inflammation in sepsis and have not proven beneficial, and perhaps it's because there's an important balance of the inflammatory response that needs to be maintained. Nonetheless, there's a downstream effect that results in vasodilatation And we've talked about some pressors that we use to try to treat that. Myocardial depression, an active area of ongoing investigation in terms of the cardiogenic response to sepsis. Tissue microthrombosis, and there have been attempts to try to address this issue, and still ongoing studies in this area. And neuroendocrine effects. Clearly there's dysregulation of the neuroendocrine axis and critical illness, and we'll talk a little bit about the use of steroids in sepsis and where that stands currently. There's been increasing appreciation that the macrocirculation is critical, supporting the blood pressure, and that the sooner you support the macrocirculation, you're likely to have a beneficial effect on the microcirculation, shown here by activation of the endothelium and platelet leukocyte aggregates and so forth. And as these cellular aspects are dysregulated, tissue microthrombosis and tissue injury then develop. So the belief is summarized in what I like this diagram, not only because of the thunderbolt showing that time is the organ here, but the thought is that there's an initial hit. There's some interaction between the initial hit and the individual in terms of what their comorbidity, perhaps genetics. The sooner you get to someone, the likely, we know that from the data, that the sooner you resuscitate someone, the more likely you are to have a beneficial outcome. If circulatory shock and inflammation develop, there's an entire disarray of microcirculatory effects that we won't talk about in detail, but involves the endothelium, a variety of different cell types, smooth muscle cells, the coagulation system. And then at the organ failure level, there are two major paths that are believed to contribute, likely both in different times and different ways are likely. One is this aspect of microcirculatory shunting. So even if you deliver oxygen to the tissues, it may not be able to get to certain tissue beds because there's microvascular thrombosis. And the other is this notion of cellular distress or hibernation, that even if you get oxygen delivery to certain tissues, the cells may be stunned or paralyzed in a way that they can't uptake oxygen, or have a process termed mitochondrial dysfunction, where the engine of the cell can't process or utilize the oxygen appropriately, thus producing organ failure. And the thought is that the sooner that we resuscitate the macrocirculation, the sooner we get to patients with appropriate care, the less likely we are to have this microcirculatory disarray. So just to talk more granularly about how we approach sepsis, how we think about sepsis in terms of therapies, and I'm going to talk about our current approaches to fluid management in light of the history that I presented to you in the beginning. So first and foremost has been the hallmark of sepsis management for 200 years is source control. We can apply any resuscitative strategy or any molecular therapy, but if we don't get rid of the inciting source of infection, we will have an exceedingly difficult time in treating the patient successfully. So early, broad, empiric antibiotic therapy within an hour is recommended. Each hour of delay, as I'd mentioned before, there's data that there's a linear increase in mortality. This is not the time to be elegant. It's the time to get every organism covered that could be possibly causal in this scenario. If there's a source of infection that will not be covered by antibiotics, either because it's walled off or because of a piece of hardware, then it needs to be removed for source control. If it's a catheter or an abscess, it needs to be drained, or an empyema, et cetera. And then once we know the pathogen, we can narrow therapy appropriately after we have culture data or have a better idea of what the infection is and what the process is and how to treat it. So source control is critical. As I mentioned, how do we think about fluids? What do we do? What's our approach now in light of the data that I showed you? So we know that oxygen delivery is critical, and filling the tank, optimizing cardiac output is critical for oxygen delivery. Oxygen delivery is the cardiac output times the arterial oxygen content, and as we know, the components of cardiac output are the stroke volume and the heart rate, and the stroke volume components are LV, EDV, and contractility. And as we said already, you may increase the systemic vascular resistance with a pressor that might increase the mean arterial pressure, and this is the right atrial pressure here. You might increase the mean arterial pressure, which is the major component of this side of the equation, but that could be at the expense of cardiac output. So we have to be certain that we are adequately filling the tank, though, as we said, not overfilling the tank. And then what are the components of arterial oxygen content? So it's 1.34 time, or a standard, times the hemoglobin times the arterial oxygen saturation. So this was the rationale behind use of red cell transfusion in the early goal-directed therapy initial protocol. Though, as I told you, that has faded from popularity, given more recent data about red cell use in the ICU supporting a restrictive transfusion strategy, and the more recent data about early goal-directed therapy. So what sort of volume should we use? As I told you, the predominant fluid over time has been crystalloid, though there have been a lot of studies of colloid for reasons that I'll discuss in 1 minute. We know we have to restore intravascular volume. We need rapid and aggressive use of resuscitative fluid, certainly early. The studies in adults suggest bolus infusion, and we talked already about avoiding vasopressors if not absolutely necessary, and of course treating the underlying problem. And this was a landmark study called the SAFE trial for all comers with shock, which examines the use of colloid versus crystalloid, in this case albumin versus saline. And what was interesting is that the probability of survival was no different between the two. There have been concerns about harm of albumin in certain subgroups of patients, those with neuro-related trauma. And then there have been questions in subgroup analysis of whether there might be benefit in sepsis patients with albumin, and that has led to a wide array of studies, really none of which have shown any benefit of albumin over crystalloid. This is the most recent one of those studies that came out 3 years ago. And this particular study looked not at albumin resuscitation, but really albumin replacement, in patients who needed or were felt to potentially might benefit from that. And they looked at about 1,800 patients and compared crystalloid versus crystalloid plus albumin, and there was no difference in 28-day mortality or other secondary outcomes. And so there really still exists no supportive data for use of colloid in place of crystalloid. This is another recent paper that I'll just mention because it's been a lingering debate as to whether there might be a benefit for some patients of maintaining a higher mean arterial pressure. Would there be a subset of patients where use of pressors to keep the blood pressure higher might be actually beneficial? And that question has been raised for patients who might, for example, with renal perfusion issues, might benefit from a higher mean arterial pressure. But this and other studies have shown similar results, that targeting a higher mean arterial pressure versus a lower mean arterial pressure showed no difference in 28-day or 90-day mortality. And in fact, there may have been side effects from more use of pressors in the high target group, and it still remains somewhat dubious in those with chronic hypertension as to whether there was any benefit for renal perfusion. But in aggregate, there does not appear to be a benefit for the large majority of patients with higher mean arterial pressure. So the targets for resuscitation remain a MAP of 65. We won't go into detail because there's not sufficient time to do so, but I'll just make a note that there remains ongoing debate about what type of crystalloid. So if there's no particular benefit of albumin, it's more expensive and carries other potential risks with it. We still favor crystalloid. Is there a particular type of crystalloid? And there have been questions over the years as to whether there's a danger of use of normal saline because of the chloride load or effects on renal function. The studies to date have not given a clear answer. There's no clear answer as to the optimal fluid. It's not clear that there's any harm from any particular type of crystalloid that's used, assuming that the correct crystalloid is used in correct patients. For example, if you use lactated ringers, you have to know that there's potassium in lactated ringers in contrast to no potassium in normal saline. So someone who has kidney injury who may not clear potassium, you have to be careful about use of potassium. And there's some other fluid supplementation flavors here that have been tried in different studies, and there's really no clear data as to benefit of any particular type of fluid. Still, largely in our medical ICU, saline is often used as the first fluid of choice, and in many surgical ICUs, lactated ringers might be used as the fluid of choice with the caveats that I told you. But there's quite a bit of overlap. And I think all agree that if normal saline is the primary fluid to be used, it's reasonable to certainly monitor the chloride load, and we'll often consider switching to LR lactated ringers if the chloride load after a fair amount of saline begins to rise. So I just want to share with you the current surviving sepsis guidelines, taking into account all the things that I just told you, the early goal-directed therapy data, the data about crystalloid versus colloid, the data about types of fluid, and this is the current, most recent surviving sepsis guidelines, and this is advised within the first 3 hours. So for patients with sepsis-induced hypotension or an elevated lactate, this algorithm incorporates the surviving sepsis campaign as well as CMS values in terms of recommendations. The recommendation is if there's not a concern regarding an oxygen requirement or cardiac dysfunction or renal dysfunction, that an initial fluid bolus, 30 mils per kg, is a reasonable initial fluid trial, and then to continue to balance fluid resuscitation and vasopressor dose to maintain tissue perfusion and minimize interstitial edema. How we do that is left up to the investigator, looking at the blood pressure and the heart rate response, urine output, perhaps using ultrasound to look at filling pressures, using the central venous pressure or central venous saturation, which is not universally recommended for all patients any longer as it was for early goal-directed therapy, looking at measures of pulse pressure variation, for which there are both bedside and commercial ways that people have tried to do this, looking at lactate clearance, and I'll show you some data behind that, looking at response to fluid balance or a passive leg raise. And then the guidelines suggest that one might consider albumin if very large volumes of crystalloid are required. Again, with the hope being to minimize interstitial fluid volume, but crystalloid is still the initial recommendation. This recommendation is modified a little bit, again, to be judicious about fluid balance in patients who have oxygen requirements or those who have other limitations to large volumes of fluid. So in someone with pneumonia or lung injury or an oxygen requirement, one might modify the rapidity or the rate of fluid administration and monitor those patients carefully, similarly for patients with renal or cardiac dysfunction. But the main recommendation remains early antibiotics, early fluids, and then carefully targeted managed fluid resuscitation. The CMS guidelines suggest a baseline lactate, and then if elevated, to get it again at 6 hours in terms of reimbursement criteria, and that's based on 2 trials. This is one of at least 2 trials. This is one of those trials that came out 7 years ago, suggesting that lactate clearance, either 10% or 20%, depending on the study, was as reliable as the central venous saturation in terms of a goal of resuscitation in sepsis therapy. What about catecholamines? I will go fairly quickly through some of these slides just because I think we think about these a lot. As many of us know, there's a range of alpha effects of catecholamines, with phenylephrine being nearly pure alpha, all the way to beta, and agents like dobutamine have more beta effects. Dopamine and norepinephrine and epinephrine are here in the middle. Dopamine used to be a pressor of choice and has fallen by the wayside for reasons I'll discuss in a minute as a pressor of choice. Norepinephrine still really remains the pressor of choice, with epinephrine as a second-line pressor, and I'll talk also about that. And they have a mixture of alpha and beta responses here. So norepinephrine really has emerged as the pressor of choice, in part because of this study that came out in 2010, which was looking at dopamine and norepinephrine in the treatment of shock. And this was all types of shock. They looked at about 1,600 patients, and there was no difference in the 28-day mortality. What was interesting in the subgroup analysis that was undertaken, dopamine showed an increased rate of arrhythmias, which is not surprising to those of us who have used dopamine at the bedside. And what was interesting that hasn't really been explained is that there was an increased 28-day mortality in the cardiogenic shock subgroup in those who were on dopamine. Whether that was related to arrhythmias is not entirely clear. But as from this study and from other, for other reasons, dopamine has really been relegated to sort of a niche pressor, as I'll tell you in just a minute. Epinephrine has really emerged as a second-line pressor after norepinephrine, in part because of this study in The Lancet from 10 years ago. They looked at about 300 patients with septic shock, and they compared norepinephrine and dobutamine, if needed, versus epinephrine, and there was no difference in either the primary outcome of 28-day mortality or the secondary outcomes. And finally, I want to talk a little bit about vasopressin, because that's really gained a lot of traction in recent years, with the thought being there might exist this entity of vasopressin deficiency in sepsis. And could we use that to our advantage if we replete this vasopressin deficiency? So there was a trial in 2008 looking at vasopressin versus norepinephrine infusion, and the title's a little bit misleading. It was examining vasopressin and norepinephrine versus norepinephrine alone in patients with septic shock. So the rationale for vasopressin repletion is based in part upon studies like this, which shows that a dog subjected to hemorrhagic shock, if you take sections from the brain, the neurohypophysis, you can see that there's less vasopressin staining in the brain after hemorrhagic shock and hypotension. So this trial was highly awaited. It looked at about 700 patients with septic shock. They compared norepinephrine versus norepinephrine plus vasopressin, and there was no difference in 28-day mortality, which is the primary endpoint, which was disappointing in this trial. What was interesting is that there was a subgroup of less severe septic shock patients who appeared to have improvement with vasopressin. And this was a subgroup analysis, and many people took away from this some hope that vasopressin may be of benefit as a rescue pressor, meaning could you lessen the requirements of norepinephrine by using vasopressin, perhaps? And then an additional trial that has come out since that time, following up on this question of whether there's a subgroup of patients or a sub-phenotype of benefit that might be beneficial with vasopressin. And this particular trial has been highly discussed and is still being analyzed for some of the sub-endpoints. But they examined about 400 septic shock patients, and they looked at vasopressin steroids versus vasopressin versus norepinephrine and steroids versus norepinephrine. So it was a complicated trial trying to look at an intersection of benefit between vasopressin and steroids, in particular at kidney failure-free days. And there was no difference in this trial, and it was not obvious that there was a clear renal protective effect observed in this trial. Nonetheless, there's still, I believe now, fairly widespread use of vasopressin in septic shock, and I'll show you here in the most recent Surviving Sepsis Campaign guidelines what the recommendations are in that respect, and I think what many people are currently using in terms of vasopressin and consideration for steroid administration, which we'll talk about very briefly toward the end. So as talked about, after fluid resuscitation for persistent hypotension, or in the setting of persistent hypotension that's refractory, the initial recommendation is norepinephrine and titrated to a dose. As said here, evidence-based medicine does now allow the firm establishment of upper dose ranges of these pressors, and the dose ranges expressed are based on the author's interpretation of the literature that does exist in personal experiences. Maximum doses in any individual patient should be considered based on physiologic response and side effects. So that caveat with the dosing. If the target is achieved, it's recommended that one could continue norepinephrine or consider a quote-unquote sparing effect of vasopressin. If the patient is not responsive to norepinephrine, then consideration of vasopressin to reach the MAP target. And as indicated here, I'll talk very briefly, but there really is no great data as to who really benefits from steroids. The most recent trial that we have suggests that patients with refractory shock can be considered for steroid administration just on the basis of refractory shock. So in this scenario, this patient might be a refractory shock patient. One could consider low-dose steroids. If the target is not achieved, as I mentioned before, epinephrine is now the second pressor of choice after norepinephrine, with vasopressin is perhaps a sparing agent as listed over there. And in this scenario, the guidelines are suggesting that this patient now has refractory shock and supports administration of steroids, but I'll talk very briefly about the data behind that in a minute. And then once you're considering an additional pressor, there's not a lot of guidelines. One can consider additional use of alpha agents such as phenylephrine. And as mentioned here, dopamine has really fallen out of favor as the initial vasopressor. It says consider dopamine as a niche vasopressor in the presence of sinus bradycardia, because again, we know it promotes tachycardia. And as many of us have done, if patients are tachycardic, phenylephrine, an alpha agent, may be less tachycardia generating. So very quickly, a few points on adjunctive sepsis care. As I mentioned, we don't have a lot of great data about what to do about steroids in sepsis. If someone has absolute adrenal insufficiency, we give them steroids to treat the adrenal insufficiency. This concept of relative adrenal insufficiency, does someone just not have enough quote-unquote juice to get through their illness? We used to think about doing cord stim tests and subdividing patients based on the response to that. The more recent data doesn't suggest that there's benefit of doing that. So as mentioned on the prior slide, perhaps consider low-dose steroids only for the sickest patients not responsive to vasopressors. We won't talk here about glucose management, but we used to pursue tighter glucose control based on earlier trials. Now the data are to adjust based on a glucose of less than 180, less tight control than what we did in prior iterations. Low tidal volume ventilation that you'll hear about in a separate talk. As we mentioned, once patients are hemodynamically stable with acute lung injury, there's data to support judicious fluid management and even promoting a negative fluid balance as tolerated. And then we're moving away from central line insertion for everybody with sepsis if we can get them through the resuscitative period without it. And even for those who need it, there's likely a lot of benefit. We know the data supports a lot of benefit for sterilely inserting lines, removing them when they're no longer needed, and careful attention to maintenance type of care. So as an overview, find these patients early. The earlier we get to them, the more likely we are to be able to resuscitate them successfully. Source control and early broad-spectrum antibiotics as soon as possible, within an hour for antibiotics, as much as possible. I put early goal-directed therapy here in quotes, meaning early fluid resuscitation, primarily with crystalloid. Monitor the response and monitor lactate levels. Norepinephrine is the pressor of choice. Consider addition of vasopressin as a sparing agent. Epinephrine has now emerged as a second-line pressor. There's a limited role for dopamine and neosynephrine as the initial agents of choice, as we talked about in select circumstances. We didn't talk about this, but activated protein C used to be an agent to treat microvascular thrombosis. We thought it's no longer available. There's not great data about how to use steroids, but you can consider low-dose hydrocortisone for patients with sepsis-induced refractory hypotension, despite fluids and pressors. We didn't talk about this in detail, but I mentioned that we now target a glucose of less than or equal to 180, and the studies have suggested that it's important to avoid bouts of hypoglycemia. Those are likely harmful. And then careful standard ICU care, ventilator bundled, prophylaxis is indicated, central line care. And as a timeline, so the patient arrives, antibiotic source control, early fluid resuscitation, early goal-directed therapy in quotes, meaning targeted fluid resuscitation. If the patients are not getting better, we don't have activated protein C, might consider hydrocortisone, low dose. If they're getting better, that's great. We narrow antibiotics based on cultures. If not, we are really in a data-free zone, and behooves us to reconsider whether they're septic. Is there a superimposed additional shock process going on? Have we missed a source? Is there an additional role for steroids for some reason? And unfortunately, sometimes we have to consider that patients may not be improving. So very quickly to go through 2 questions just to review some of these points. A 47-year-old woman with alcoholic cirrhosis is brought to your emergency room with fevers, confusion, shortness of breath, and worsening ascites. The systolic blood pressure is 50, heart rate of 150, respiratory rate of 40, oxygen saturation 80%, with a CVP of 4. Chest x-ray shows diffuse infiltrates, and peritoneal fluid returns with a leukocyte count of 1,000. That's largely polys. Initial management of hemodynamics should entail either vasopressin, norepinephrine plus Lasix, intravenous fluids, or dobutamine. And the answer is intravenous fluids, and this is early goal-directed therapy in quotes. The sort of top part of this algorithm, which again, we've moved away from early goal-directed therapy as sole concept, but this notion of an early fluid resuscitation followed by or in parallel with pressors to maintain perfusion is really the hallmark of early resuscitative strategy. You administer broad-spectrum antibiotics to treat presumed spontaneous bacterial peritonitis, SBP. Give her supplemental oxygen, and after fluid resuscitation with 3 liters of crystalloid, her heart rate comes down to 100, her blood pressure has risen to 65, systolic, with a mean arterial pressure of 50, and the CVP is 13. You next order vasopressin, norepinephrine plus Lasix, red cells, or dobutamine. And the answer here is norepinephrine. By any metric, she is fluid resuscitated. She actually now has an oxygen requirement. Her central venous pressure has risen. She appears to have been fluid resuscitated to a point where additional fluid is likely not to be beneficial, and it's at this point where one adds a vasoactive agent, and norepinephrine would be the first agent of choice for that. And again, I put early goal-directed therapy in quotes here. Again, this protocol has been, the top part of this protocol has been adapted into some of the other management slides that I showed you, but I think this sort of notion of early fluids judiciously, followed by pressors, is a really helpful way to picture it.